We're going to go ahead and kick off the third peripheral session, Vascular Disease Therapies, Established and Upcoming. On behalf of myself, my name is Teresa Carmen, and my co-moderator, Herb Aronow. We thank you for attending, and we're going to get started. Dr. Aronow is going to speak on when and how I prescribe rivaroxaban for my PAD patients.
Thanks, Terry. I want to thank the CVI organizers for the opportunity to present in the vascular session today. We've got a lot of great content coming up. I know we're starting a couple of minutes late. We'll eat into the discussion. We'll get caught up. I'm going to spend my time focused on two trials. There are really two trials that I think inform the decision-making here, COMPASS and Voyager PAD. COMPASS, as many of you know, is a 27,000 patient trial, 33 countries, over 600 centers, and it enrolled patients with PAD, CAD, or both. And then it randomized them to one of three arms. And I'm going to focus on two of those treatment arms today. One is low-dose aspirin alone, 100 milligrams daily, and the other is rivaroxaban 2.5 twice daily plus low-dose aspirin. The primary endpoint was cardiovascular death, MI, or stroke, and the trial was stopped for superiority of dual pathway inhibition, that is low-dose rivaroxaban plus aspirin, when compared with low-dose aspirin at 23 months follow-up. You can see the Kaplan-Meier curves on the right, and I think I would highlight on this slide, and I did, the absolute risk reduction between the two groups was 1.3%, and I think it's important to bear that in mind as you think about what's the number needed to treat here. So COMPASS, as I mentioned, enrolled patients with PAD. In fact, there were almost 5,000 of them, and the inclusion criteria, you can read them, they're on the left of the slide here. These were patients with either symptomatic or asymptomatic PAD. And on the right, what you can see is part of the subgroup analysis. When we look at the overall primary endpoint in the trial, among patients who had PAD versus those who didn't, and ask the question, was there any difference between how much benefit was seen with dual pathway inhibition with those with versus without PAD? The answer is no. The overall absolute risk reduction was about 1.8%, and the p-value for interaction was not significant. So again, whether you have PAD or you don't have PAD and you're in this trial, you saw benefit. It didn't matter. And again, that overall risk reduction was even greater in the patients with PAD, 1.8%, than it had been in the overall trial, 1.3%. So could we delve even further into that? Are there higher risk patients that we could identify? That's what Kaplovich and colleagues looked at. They developed this construct, two constructs really, around high-risk limb presentation and high-risk comorbidities. So what they did was, you'll see the bar graphs on the right there, they looked at the event rates in patients that had, so for high-risk limb, who had had a prior amputation or a prior lower extremity revascularization, or Fontaine class 3 or 4 as opposed to 2, right? They also looked at patients who had high-risk comorbidities, like those with heart failure, or chronic kidney disease, or polyvascular disease, or diabetes. And you can see next to each of those comorbidities and historical factors, a percentage, that's the percent of people who had an event out to 30 months, who had a MACE or male event. So these are really high-risk patients. And when we look at patients like this, we see that there is an absolute risk reduction of 4.2%. So this is a very high-risk group in whom we see a whole lot of benefit. Importantly, because you always want to ask the safety question, there was only a 2% absolute risk increase in major bleeding in the same patients, and a 0.4% absolute increase in fatal or critical bleeding. So it comes at a cost, but I would argue that that cost is outweighed by the benefit. Now, enter Voyager PAD. Unlike COMPASS, which had both patients with coronary disease or PAD to get enrolled, these patients all had to have PAD. There were over 6,500 of them. They were enrolled from 34 countries and over 500 centers. They had to have undergone a prior successful peripheral vascular intervention. And by that, I don't mean just endo. It could have been open revascularization as well. Within the prior 10 days, they had to have lifestyle-limiting symptoms, that is Rutherford class 3 to 5, infrainguinal disease, and an abnormal ABI or TBI. They were excluded, and I didn't mention it but should have, as were patients in COMPASS if they were at high bleeding risk or HBR, or if they had a recent history of an ischemic stroke or any history of intracranial hemorrhage. They were randomized according to the scheme shown on the right side of the slide, and they were followed up for a median of 28 months. Here you can see the Kaplan-Meier curves out to 3 years. You'll see that the risk in those that were on aspirin alone was almost 20%, where it was closer to 17% among those on dual pathway inhibition. That's an absolute risk reduction of 2.6% in that trial. The hazard was reduced by about 15%, and that was a statistically significant reduction. If you look at secondary endpoints, and there were a number of them, some of them were just the components of the primary endpoint, and then there were others on top of that. It's a little bit hard to see. It's certainly hard for me to see from up here, but acute limb ischemia, which is what I highlighted in the upper portion of this slide, which was a component of the primary endpoint, was significantly reduced. The hazard was reduced by about 33% over the course of the trial. And then unplanned revascularization for recurrent limb ischemia, not necessarily acute limb ischemia, but any ischemia. So it could have been critical limb ischemia, acute limb ischemia, recurrent symptoms. That was also reduced significantly over the course of the trial. So important endpoints. Again, what about safety? So if we look at safety outcomes, you'll see that the primary safety endpoint, which was TIMI major bleeding, was no different between the two arms. There was not a statistically significant difference there. However, ISTH bleeding was significantly greater in the dual pathway inhibition arm at almost 6% versus just over 4% in the aspirin alone arm. BARC major bleeding, on the other hand, not significant. So it depends on how you ask the question when it comes to safety. There is some signal of bleeding, which is expected with more potent antithrombotic therapy. So I think many of you who either take care of patients who undergo revascularization or who perform revascularization, whether endovascular or surgical, may also use clopidogrel and are often faced with the dilemma, what do I do if I now understand that in certain patients, especially after revascularization, dual pathway inhibition can produce MACE and MAL. What do I do with my clopidogrel? What do I do with my DAP? So Will Hyatt did a very interesting study, a sub-study, in Voyager Pad, where he looked at patients on clopidogrel versus those that weren't. Now, first of all, he found that the endpoint, the primary endpoint, was reduced to the same magnitude, or the same relative magnitude, in patients who had been on clopidogrel after the revascularization but before being randomized, as those who weren't on clopidogrel after the revascularization before they were randomized. So that's important. Clopidogrel didn't take anything away from the primary endpoint. It didn't take anything away from the impact of dual pathway inhibition. It's interesting to note, you may have observed, that those without clopidogrel actually have higher event rates in both arms, both the aspirin alone arm and the dual pathway inhibition arm. But again, the take-home point from this slide is just that we didn't lose any efficacy with addition of clopidogrel. You would think you probably wouldn't, but it's worth testing that hypothesis. On the other side, right, is bleeding. So did bleeding change when patients were on clopidogrel plus dual pathway inhibition or clopidogrel plus aspirin? Now, what you should know about Voyager Pad is that you were allowed to be enrolled if you had revascularization recently as long as the intended duration of DAPT was not greater than 30 days, greater than 6 months. So as long as it was up to 6 months, that was okay. So what you can see in this slide here is if we look at patients, placebo are in red and rivaroxaban are in purple. You can see TIMI bleeding on the far left. You can see intracranial or fatal hemorrhage in the middle and ISTH bleeding on the far right. There's no interaction. So what that means is there's no significant p-value, interaction p-value. It means that the results that were observed in patients on clopidogrel when it came to safety were no different than the results observed in people that weren't on clopidogrel. So that's an important observation in this trial. Again, we did see there was more ISTH bleeding, as I mentioned earlier, in patients that were on dual pathway inhibition versus those that were only on aspirin, but we didn't see any more bleeding, even with that bleeding endpoint, when we added clopidogrel to it overall. What we did see, and this was interesting, they did another analysis looking at the duration of clopidogrel. So I mentioned you could be on clopidogrel for up to 6 months. So there were patients who weren't on any. There were some patients that were on less than or equal to 30 days, and there were some patients that were on sometime between 30 days and 6 months worth of clopidogrel. And what we saw is that the bleeding risk really didn't increase at all up to 30 days. We did see an absolute risk increase of about 2.8% in patients that stayed on between 30 days and 6 months. So is there some increased hazard, increased risk? There certainly is. And so that's what you have to balance with the anticipated benefit that you'll see, especially if you're pulling out the higher risk patients for this therapy. So when do I prescribe dual pathway inhibition with low-dose rivaroxaban and low-dose aspirin? Patients with symptomatic lower extremity PAD who've had without revascularization recently, but who have either high-risk limb presentations or high-risk comorbidities. Patients who've had a recent revascularization procedure for symptomatic lower extremity PAD. Those who are not high bleeding risk from the above two groups. Those in which there is no plan for a longer-term dual antiplatelet therapy than 6 months from the above groups. And finally, those who don't have a history of recent ischemic stroke or any history of intracranial hemorrhage from those groups. Thank you very much.
Okay, good afternoon, and thank you for the privilege of the podium. These are my disclosures. So for full disclosure, let me just say that this is my approach as someone who's a vascular surgeon who treats complex deep venous disease. And this is a sort of a smattering of the complex levels of different types of patients that I deal with regards to thrombosis, in the setting of thrombosis. And so for me, failure is not an option. These cases require quite a bit of work, quite a bit of planning, and medicine and anticoagulation is just one critical component to achieving the best outcome. Rethrombosis after stenting is really just a nightmare. The therapies to recanalize thrombosed stents are not good. You often leave a layering of thrombus. That's in the acute setting. Chronically, they're even more challenging. And again, anticoagulation is a critical part of the recipe for me. So when we think about anticoagulation in patients with complex iliofemoral disease, high-quality evidence for the ideal antithrombotic approach is lacking. Optimal clinical management following venous stenting procedures is pretty ill-defined, as we are still trying to understand what are the risk factors for rethrombosis. In general, dedicated venous stent patency data is less in the thrombotic versus the non-thrombotic patient. And here we have just some of the longer-term data presented by two of the endovenous stents, Abre and Cook, for a 24 and 36-month period. Certainly, these are a bit lower than the non-thrombotic patients and not perfect. And when you think about the age of the patients that are getting these, I think 2 years and 3 years, still is early-term data. So how can we make these better, and where does anticoagulation play a role? So it starts with considering the patient, what the patient comes to you with. So their age, prior or recurrent DVT, was the episode provoked or unprovoked? Was there a workup or a prior known hypercoagulable condition, a family history? What are their bleeding risks? I'm about to consider a duration period of anticoagulation, and are they safe to undergo a procedure? Are they going to tolerate anticoagulation? Is there active malignancy, inflammatory disease? What is their starting venous anatomy? Again, in any venous reconstruction, inflow-outflow is critical to success. What's their renal function? That sometimes helps guide which anticoagulation I can give the patient. Have they failed prior anticoagulation? What's their compliance? They have to be compliant for this to work. This is a commitment on our end, on my end, and the patient's long-term. They have to comply with medication. Do they have insurance coverage? I'll talk about why. I mean, I like to do injectables up front for multiple reasons. And social support. I think it's very challenging when patients don't have social support to comply with anticoagulation. And when thinking about why I choose the regimen I choose, you have to think about the risk factors for VTE. And we know Virchow's triad, which is stasis, hypercoagulable state, and endothelial injury. But inflammation is becoming more and more well-versed in the deep venous space, especially in the thrombosis patient, and the role of inflammation, especially early on, and how you can think about that when you're choosing the anticoagulation of choice after an intervention. Risk of recurrent VTE increases per patient year depending on the scenario, whether it's transient a chronic event, unprovoked, or recurrent unprovoked event. The implication of rethrombosing a long segment iliocaval reconstruction with stents is not insignificant. Patients are at increased risk of worse post-thrombotic syndromes if they occlude the stents. They can progress from a moderate to a severe post-thrombotic symptom scoring. They have worse quality of life, and overall, technically, you achieve poor technical results in a redo scenario. And so I just wanted to bring to your attention a couple of really key articles that have come out in the last year. And this is a consensus report from really experts in the field, which looked at the available data and the lack of data in particular, and set priorities for research endeavors that will hopefully provide some information for patients with these issues and how we should choose anticoagulation. So characterization of biologic processes leading to in-stent stenosis and rethrombosis, identification and validation of methods to assess venous flow dynamics and their effect on stent failure. So this goes into play in the optimizing inflow, the functionality of the patient. Elucidation of the role of inflammation in anti-inflammatory therapies. There are multiple being considered out there. And clinical studies to compare antithrombotic strategies and improve venous outcome assessment. And this is one key article with a consensus, as well as one that recently followed from a similar group, and including other leaders in the venous space that I think are very important to help guide decision-making and understand what's the data current to date. So what's my approach, again, as a vascular surgeon who does deep venous complex work? Well, based on expert data to date and consensus data, I like Lovenox following these procedures. I do at least 1 month of twice daily Lovenox, and so this is where that whole support system and compliance and insurance comes into play, because I prepare ahead of time if I can, certainly not the acute setting, but if a patient's coming to me from home, let's say for a chronic disease, I pre-authorize their Lovenox, I have it ready to go, it's at the bedside, they're gonna get a Lovenox in the PACU for me. And I continue this twice a day, lots of nursing education. I admit them for 24 hours to get that education so they're comfortable, and I feel good when I send them home that I gave it the best shot to have a good compliance. I transitioned them to a BID DOAC at 1 month based on clinical exam and surveillance duplex of the stents, both of the stents and the inflow, so I do lower extremity duplex. Around the 6 to 12 month, I'm more of a 12-month kind of person, because again, these are quite a bit of work and the implications of thrombosis are significant. I do this period of anticoagulation and then reassess at the 1 year, again, with a clinical exam as well as an ultrasound-based exam to decide if this is a good time to transition to off or continue anticoagulation or make a change. If a patient is hypercoagulable, has recurrent DVT, has stent stenosis based on exam or CT or venogram, if I had to ever do one, with suboptimal inflow, extensive stenting into the cava. Sometimes we have scenarios where we've gone from profunda all the way to the renal veins. And malignancy, I think for me, these patients are lifelong anticoagulation patients. And certainly close collaboration with my vascular medicine specialist is key. These patients are multidisciplinary. They require a team effort, and I think that provides certainly some of the tools for success. Thank you very much.
Tim or Paul, and he's going to speak to us about the case for PCSK9 inhibitors in peripheral arterial disease.
Thanks, CVI course directors, for inviting me. In next few minutes, I'm going to discuss role of PCSK inhibitors in treating PAD. We go to next slide. Next. Oh. I have no disclosures. So patients with PAD are at very high risk for cardiovascular outcomes. The lower the LDL cholesterol, the lower the subsequent cardiovascular risk reduction. Despite guideline recommendations, the study shows that in symptomatic PAD, almost 3/4 did not achieve the LDL goal to less than 70. And also, approximately half of them had LDL cholesterol more than 100. So PAD is equivalent to CAD. So all patients with PAD should be on statin therapy. It's a class 1 recommendation. What are the goals of LDL in PAD? The ACCHA recommends LDL level less than 70 milligram per DL in very high risk ASCVD patients, and or if more than 50% reduction from the baseline cholesterol. They did not specifically recommend PAD versus CAD, but European Society of Cardiology guidelines, they specifically recommend less than 55 LDL for PAD patients. Very high risk PAD in atherosclerotic cardiovascular events, the symptomatic PAD is considered a major ASCVD event. How do we achieve this goal? Of course, with high statin therapy, high intensity statin therapy, or maximally tolerated statin therapy. It's a class 1. But if the LDL is more than 70 while on statin therapy, addition of non-statin therapies such as ezetimibe or PCSK9 inhibitor is reasonable. When to add PCSK9 inhibitor? In very high-risk patients, if LDL remains more than 70 or maximally tolerated statin therapy and ezetimibe, then it is reasonable to add PCSK9 inhibitor. So there are 2 randomized trials, Voyager and Odyssey outcome trials, specifically investigated the PCSK9 inhibitors and cardiovascular outcomes. So Odyssey outcome trials is almost 19,000 patients with ACS patients on maximal statin therapy with ezetimibe, and this study showed that there is a significant reduction in cardiovascular outcomes with alirocumab, with an absolute reduction is 1.5%. The Voyager trial also evaluated the alirocumab in almost 28,000 patients, patients who are LDL was more than 70 with maximal medical therapy, but not all patients was on ezetimibe, either or. And this study exactly showed the similar results like Odyssey outcome trials, and it showed there is a significant reduction of primary endpoint of cardiovascular outcomes with an absolute risk reduction is 1.5%. So these 2 trials showed that further reduction of LDL can be achieved in between 43% to 64%, and addition of PCSK9 inhibitors associated with significant reduction of cardiovascular events in very high-risk patients. So can we extrapolate this data to PAD patients? What is the specific evidence of PCSK inhibitor in PAD patients? So the Odyssey outcome trial specifically looked at peripheral arterial disease and venous thromboembolic events after the ACS, and it showed that if patients with alirocumab have almost 31% relative risk reduction, and PAD or PAD with venous thromboembolic events. And this study specifically showed that baseline lipoprotein A is the predictor for reduction of PAD events, but not the LDL-C. The same study specifically looked at polyvascular disease and cardiovascular outcome in patients with acute coronary syndrome, and it shows that patients with 3 or more territory of the vascular atherosclerotic disease had the greatest benefit, and it showed that 13% absolute risk reduction, and if they have a 2-vessel involvement, then it's 1.9% absolute risk reduction. But most important, I think the Voyager trial is the specific trial that specifically looked at the patients with PAD and cardiovascular outcomes and limb outcomes. So almost 3,600 patients, and they looked at the major limb events such as acute limb ischemia, major amputation, or urgent peripheral revascularization for ischemia. And this study showed in PAD patient, there is 3.5% absolute risk reduction in cardiovascular events. This benefit remains even the non-PAD patients too, but with a lesser extent. The major adverse limb events also significantly reduced in all patients and also in the PAD subgroup. And The MACE or male, as you can see here, that in PAD patients, there's an absolute risk reduction is 4.1%, and number needed treatment is 25. I think this is one of the lowest number needed treatment I ever see. So this PAD subgroup showed that lower the LDL-C, the lower the benefit, and this LDL, if it's even less than 10, even higher the benefit is. The European Society of Atherosclerosis, they combined this Odyssey and Voyager trial, and they found that treatment with PCSK9 inhibitor on top of the maximally tolerated statin therapy reduced 24% cardiovascular events. So in summary, patients with PAD are at very high risk for cardiovascular events. All PAD patients should be treated with statin with the maximal tolerated doses to reduce the LDL at least less than 70. And statin showed that it reduced MACE and/or MEL by 25%. But the addition of PCSK9 inhibitor further decreased the cardiovascular events and limb events. So PCSK9 inhibitors should be added if LDL remains more than 70 or more than 50% higher than the targeted goal, despite statin therapy with or without ezetimibe. Thank you for your attention.
Thank you very much. So we have a panel discussion scheduled. We are running just a little bit over, so we probably can't take the whole time, but I think we certainly have a few minutes. I'll start by asking whether there's any audience questions. If you have a question, maybe raise your hand so I can see you, and there's a mic right there on the floor. Please feel free to come up. If there's nobody with an immediate question, we have one. Do you mind, just because we're recording the sessions, if we have you head to the mic? Thanks so much.
Great session. Thank you so much. So I do have a question about the Voyager data. And, I've looked at some of the subgroup analysis because they did include both endovascular as well as surgical therapy. And I just wanted to get your thoughts because it's not really clear at this point if it benefits both patients with surgical as well as endovascular. As you start to dissect the data, it looks like it's more apparent that it may be more beneficial in surgical outcomes than in endovascular, but do you feel that we can extrapolate that to endovascular outcomes as well?
So that's a really interesting question. I'm going to start by asking you, Timur, if you don't mind commenting, since that was your subject, but we can all weigh in if there are other opinions.
So the question was in Voyager PAD data. What is can you repeat the question again?
No problem. So in Voyager PAD data, they included both surgical and endovascular patients. And so, the question arose is that, do you see the same outcomes in surgical bypass patients than you do in endovascular? And when you start to look at the subgroup analysis, it seems as though you get more of the benefit in surgical patients rather than endovascular patients. And obviously, it is a subgroup analysis, and so it wasn't really powered. But it does look like there's more of a benefit with surgical data. But do you feel like we can extrapolate that to endovascular revascularization as well?
I mean that in a lot of trials that we extrapolate some data, but I think that although the surgical group got more benefit, I think we can use the same data as long as patients are not in high bleeding risk. Then we can use the same. I would use the same dose.
Yeah, I think the problem is that it's largely a data-free zone, right? I mean, we have very small numbers in the trials, and I thought it was very provocative that there was about a 50% reduction in the risk of ALI, but it was from 0.5 to 0.25%, right? So it's hard to know. Can we just extrapolate that? And certainly, I think we all worry about stent thrombosis after endovascular intervention. So, and we need to get people to goal as far as their LDL anyway. So, maybe it's a foregone conclusion that we're doing some good beyond what we thought we were doing by, pushing the lipid lowering. I don't know if others have thoughts.
I'll just weigh in and say at the end of the day, they're both very high-risk patient categories. And while the effects on major amputation and major limb events are provocative in this. It's also, at the end of the day, about the MACE and the overall preservation of the patient as part of their cardiovascular risk factor modification. So I don't know that I would differentiate. Oh, okay. So we're all talking about PCSK9s. Got it. Do you want to weigh in on the Xarelto question?
I think I agree. If you look at the Voyager data, it looks like the benefit is actually in patients with the PTFE, the prosthetic bypass grafts, which is good for us for vascular surgery because there actually is no really good data for that. You know, we always, you know, if you ask any one of us, we put people on aspirin Plavix, aspirin warfarin, but there's a really good study that says you should put these people on warfarin. It's kind of like a gestalt, right? So at least now there's some data that suggests with the low-dose rivaroxaban, there's something to do with these people with these prosthetic bypasses. But I agree that the data for the endovascular revascularization is a little different because we've always thought to put them on dual antiplatelet, right? It's always been like an antiplatelet thing. So I think that's another area for sort of research there.
Yeah, no,
Yeah, I
appreciate
believe it's difficult to really extrapolate the outcome of the surgical benefit into the endovascular benefit, because what is a little bit conflicting regarding the Voyager data is the former experience in coronary interventions. We learned that in coronary interventions in the past, all anticoagulation did not lower the risk of stent thrombosis. It was just lowered when we introduced dual antiplatelet therapy. And therefore, it's, well, at least it should be reconsidered whether the addition of anticoagulation to antiplatelet therapy really results in a significant benefit after stent placement in the periphery. It's uncertain if you can compare coronary with peripheral vascular interventions, but at least there is some, let's say, unknown behind the outcome of the endovascular group.
Thank you, Tomas. So great dialogue around that. I know there was one other question. Go ahead.
Hi, my name is Benjamin Lee from Dallas, Texas. I have a quick question about the statin, statin use in PAD patients. So, you know, I noticed, you know, a lot of patients who get referred to, they come in with statin, usually on low-dose statin, and they are effectively able to achieve LDL level up below 70. In your practices, do you guys still push these statin levels as high as possible, and even though their LDL is on target?
Tamir, do you want to weigh in on that as well?
Yeah, no, if his LDL is less than 70, then you don't have to push for PCSK9 inhibitors. But if they have a complex PAD, multiple revascularization, and patients coming back and forth you have to think about the high risk of atherosclerotic cardiovascular events. That includes multiple MIs, multiple stroke, or symptomatic PAD, or patients with ACS. Either one of them, or if they have a so-called high-risk condition, like if you have multiple high-risk conditions such as diabetes, hypertension, smoking, CKD, multiple risk factors, then you can push below 55. The ACC/AHA does not recommend anything specific below that level.
I think in the interest of time, we'll keep moving. I'm going to invite my co-moderator, Terry Carmen, to come up to the microphone. She's going to be speaking about Wi-Fi classification. How do I use it in my practice?
All right. Thank you, and I thank the organizers for the privilege of the podium. I don't have any disclosures. So I'm going to start with the conclusion slide because I want you to keep these things in mind. The Wi-Fi classification as it stands allows us to help to comprehensively evaluate foot ulcers using a combination of wound characteristics, perfusion, and the presence of infection, and that was what it was guided for. It allows wound specialists and wound care teams to sort of comprehensively, if you will, understand the needs of the ulcer, not necessarily of the patient, but of the wound and of the ulcer itself. I think predicting wound healing and the absolute need for revascularization and limb and patient outcomes are far more complex than any single classification system can really guide us through. And multidisciplinary wound healing teams have actually, are probably our best utilized in these complex neuroischemic ulcers and these complex patients. So let's talk a little bit about where we're at. So this is a little bit older data, more than 400 million patients worldwide with diabetes. These numbers are increasing. This is older data from about 5 years ago, so we're probably closer to 500,000 at this point. And approximately 1 in 4, or 25%, will ultimately suffer from a foot ulcer. We also know that the prevalence of peripheral arterial disease is increasing, and it's estimated that about 20% of the ulcer patients seen in the wound clinics have associated underlying peripheral arterial disease. When we look at a foot ulcer, they can be very complex. Many of them are ischemic, many of them are neuropathic, and some are neuroischemic. And sorting that out really becomes one of our tasks. When we talk about clinical scoring systems like Wi-Fi, the goal of those scoring systems are to allow the health professionals to communicate between each other so we know what we're talking about and we have an appreciation for the complexity of the patient. It can help us understand clinical prognostication or the prognosis of the patient and help guide treatment. And we have to think along the lines of other clinical risk scores that we know, like SEEP, or more like the TNM model that we use for cancer and chemotherapy. We know at the end of the day, this is a heterogeneous population of patients, but at least it allows us to communicate what those patients are experiencing. So there are many different grading systems, and different wound clinics are going to use different systems, but all of these systems are designed to either look at the wound itself, for the most part, or the infectious state of the wound. And it was really only Wi-Fi that assessed the ulcer, the infection, and the perfusion status fairly comprehensively. So Wi-Fi was developed in 2013 and was actually published in 2014. It was specifically designed to help us look at patients with chronic limb-threatening ischemia, but that classification in and of itself, if I call my practitioner or my operators and I say I have a patient with CLI or CLTI, that doesn't necessarily communicate everything that needs to be communicated about the patient. It was designed also to go past what Rutherford or Fontaine had done for us from a vascular surgery standpoint, because those really excluded our patients with diabetes. So they looked at the highest risk characteristics in diabetic foot specifically that have an impact on amputation. So I'm not expecting you to read all of this, but suffice to say that all of the components, the wound, the ischemia, and the infection, are graded on a scale based on the components and the characteristics of the wound and or gangrene. When we talk about ischemia, they use the ankle brachial index as well as the absolute ankle pressure or the toe pressure, and then infection is also graded. This is actually a much more legible summary slide so that you have an idea of what we're talking about. And I think this gives us a better background. After they created this model, then they went through a Delphi consensus process, and they asked experts in the field, if you saw these patients in these different classifications, what's your perspective that they would be either very likely to heal, be likely to heal, moderate risk for healing or amputation, and then high risk for amputation or unlikely to heal. And then they created a staging system. So stage 1 patients where amputation risk is very low, all the way through stage 5 where we basically have an unsalvageable foot. So does Wi-Fi really help us predict our revascularization needs? Well, this is a retrospective study that looked at 136 patients who underwent limb revascularization. About 2/3 were endovascular and 1/3 surgical. And at the time of revascularization, they did a Wi-Fi score on these patients, and based on that Wi-Fi score, broke these patients down into quartile, where they would have a high estimated benefit from revascularization, moderate, low, or even a questionable benefit, but they were doing this as part of limb salvage. And you can see the breakdown on the right-hand side of the slide. And as expected, most of these were higher Wi-Fi classification patients. Well, what did they really see? Well, when you look at the Kaplan-Meier curves, at least for major amputation, those patients with the least likely benefit, those quartile 4 patients, didn't do as well and underwent major amputation much more frequently. But patients that were in quartile 1 through 3, they had fairly good preservation without major amputation. Ulcer healing, secondary patency after intervention, and amputation-free survival was really not different between the other groups. When you look at their 1-year major amputation rate, there's certainly amputation across the board. It's not necessarily cut and dry, but you can see most of the amputations were in those patients in quartile 4 where it was of questionable benefit, and you do see that the revascularization actually remains patent in many of these patients. So they had other wound characteristics that put them at high risk for that amputation to begin with. Well, what about predicting wound healing? This was another retrospective study. This is out of the PAVE program, which is a program run through the VA clinics, and it's a program that's designed to stratify patients to either conservative care, immediate revascularization, primary amputation, or palliative care based on a multidisciplinary approach and evaluation of the patient, whether they have their fitness status, their ambulatory status, perfusion, et cetera. Their goals were looking at wound healing, ulcer recidivism, delayed revascularization, amputation, and survival. In the interest of time, I'm going to go a little bit quickly here. Suffice to say, major amputation 10%, so fairly substantial. Overall survival 40%, which speaks to some of the things that we've talked about relative to the cardiovascular risk factor modification that needs to go on in these patients. There was really no difference in wound healing, recidivism, and things like that across all of these different categories. And when you look at the Kaplan-Meier curves, you can tell that we didn't tease out these patients terribly well in these patients who were treated medically and conservatively without a revascularization strategy. So not all of these patients are going to need revascularized. I'm going to jump very quickly because I'm short on time here. Suffice to say, another trial that looked at angiosome revascularization, that's one of our goals in these patients most of the time, looked at whether patients had direct perfusion, indirect perfusion, or pedal arch patency after their revascularization. Again, I'm going to skip a little forward here to Kaplan-Meier curves. And you can see on the top right there, whether they had indirect perfusion or direct perfusion, really no difference. What did sort of set out a little bit was that the Wi-Fi stage would help us predict a little bit. Patients with a lower Wi-Fi, less likely to have successful wound healing with this strategy. So I think wound centers need to understand that this is a very complex patient. Structured evaluation, assessment of these chronic foot ulcers is very important. The Wi-Fi allows that structured assessment, allows us to speak the same language, and it should be and could be or can be implemented as part of a comprehensive program. But not all of these neuroischemic ulcers are dependent on this revascularization first strategy, and using the Wi-Fi to help you through that process, I think, is very helpful. And with that, I'll go back to my conclusions, and we'll see how Wi-Fi helps us in the future.
Thanks so much, Terry. So we're going to change gears here and move over to renal denervation. Some of you may have been in the session that immediately preceded this one on a similar topic, but many of you, whether you were or not there, may be wondering, is renal denervation really coming back? Usman Babar will tell us.
Great. Well, thank you again for the opportunity. It's a pleasure to be here. And over the next few minutes, I will try to answer the question posed by the slide. Renal denervation, is it coming back? These are my disclosures. So before I answer that question, let us just remind ourselves of the strong physiologic links between renal sympathetic activation, as illustrated in the graphic on the far left, involving both efferent and afferent pathways in the pathogenesis of hypertension. And indeed, as illustrated in the bar graph on the right, we know that renal norepinephrine spillover, a marker of renal sympathetic activity, is higher in patients with versus without hypertension. And therefore, the promise of a catheter-based technology that can ablate the renal nerves, diminish sympathetic outflow, and lower blood pressure is obviously very appealing. And this promise was highlighted very elegantly in this case report, referenced over 1,000 times, published in the New England Journal of Medicine, where the investigators describe a 59-year-old man with resistant hypertension on 4 meds who undergoes renal denervation using radiofrequency ablation. And what the authors did is they examined the physiologic effect of this treatment. On the far left, you can see renal norepinephrine spillover is markedly reduced after renal denervation. In the middle panel, you can also see that whole body norepinephrine spillover is also reduced. And if you look at the right, you see that muscle sympathetic nerve activity is also reduced. And what this highlights is that it's not just the efferent pathways that are being blunted when we perform renal denervation, but indeed also afferent pathways that ultimately inhibit central sympathetic outflow. So while this is very promising and nice to see in case reports, obviously we need large randomized trials, and in any discussion with renal denervation, we have to discuss the foundational trial, which was Simplicity HTN-3. And of course, this was the first blinded sham control study evaluating the safety and efficacy of renal denervation using a first-generation radiofrequency catheter. The trial enrolled 535 patients with resistant hypertension, and some of the salient points of the trial are important to mention as we think about the results. One of these is that the patients were supposed to be on quote-unquote maximally tolerated doses of blood pressure medicines for at least 2 weeks prior to randomization. Denervation, as mentioned, was performed with a first-generation catheter using a single electrode, and the protocol recommended at least 4 to 6 ablations per renal artery in a comprehensive fashion involving all 4 quadrants of each respective renal artery, and the primary endpoint was change in office systolic blood pressure at 6 months. So as we know, the results of this trial were negative. The patients who did get renal denervation had about a 14 millimeter reduction in blood pressure. However, this was comparable to that which was seen in the sham group, rendering a non-significant between group effect both for the primary endpoint and for the secondary efficacy endpoint of 24-hour systolic blood pressure. And when we see a result like this, we are forced to conclude a few things. One possibility is maybe the null hypothesis is true. Maybe we cannot modulate blood pressure with a catheter. Alternatively, perhaps we underestimated a placebo effect in earlier studies that did not have a sham control. However, the investigators of Simplicity HTN-3 conducted several analyses. Perhaps this is the most important one, published by Kenzari and colleagues in the European Heart Journal, where they implicated several key features of the study that explained the results. One of these had to do with the extent of ablation. As you can see, in each of these bar graphs represents a treatment effect, and you have a larger treatment effect in those patients in Simplicity HTN-3 who had more extensive ablation performed. And in fact, only 19 patients out of the cohort of 535 had a complete 4-quadrant ablation performed. So certainly variability and lack of extensive ablation may be one reason the results were negative. Secondly, it has to do with background medication changes. As mentioned, these patients were supposed to be on maximally tolerated doses of their blood pressure meds. However, over the 6-month course of the trial, medication changes occur in about 40%, and certainly that introduces a strong confounding effect when trying to isolate the effect of renal denervation. Third, there was about a 2-week run-in prior to randomization, and that is a bit brief and may introduce regression to the mean, as elegantly explained by Professor Pocock in his paper. So with all of these concerns, a whole host of new trials have been conducted and published and reported in the last couple of years, building on the lessons of Simplicity HTN-3, both with respect to the type of device, technology, and patients. One of these is the Spiral HTN off-med trial. This uses a new generation catheter with 4 electrodes. It has a circular helical pattern to provide a more comprehensive ablation to both of the renal arteries. In this trial, the investigators actually examined the effect of renal denervation versus, again, a sham procedure in patients with hypertension who are off medication. So either medication was discontinued or they were never initiated on medication. And this elegant design allows one to isolate the effect of renal denervation independent of the confounding of background changes in blood pressure pharmacotherapy. So the results of this study are shown here. On the left, you can see large and significant reductions both in office-based blood pressure and 24-hour systolic blood pressure in the light blue as compared to the pink. And on the right, you can see over a 24-hour period a sustained reduction in blood pressure in patients who receive renal denervation compared to the sham. And that's a very important concept that highlights sort of the always-on effect that patients are realizing with renal denervation, particularly very relevant when we think about the variation that might occur with lack of adherence and pharmacokinetic differences with orally ingested drugs. Other companies have developed other technologies. There's the Radiant Solo trial that looked at ultrasound energy, again, to provide more circumferential ablation. And they looked at a very similar patient cohort with hypertension. Meds were washed out, and they examined renal denervation versus sham at a 2-month time point. And again, you can see on the right large and significant reductions in blood pressure. So 2 different trials, 2 different technologies, both examining patients with hypertension not on background pharmacotherapy, and you're seeing nice positive results. But certainly, we're not going to use this technology in patients not on therapy. We're going to apply it in patients who are on blood pressure medications. And this was examined in the Spiral HTN OnMed trial using the same spiral catheter in a cohort of 80 patients with uncontrolled hypertension, 6-week stabilization period prior to randomization. Again, renal denervation versus sham. The primary endpoint was at 6 months, but very recently, 3-year data were presented from this study. And you can see on the far left, sustained durable reductions out to 3 years in the light blue compared to red. And again, at 36 months on the right, you see that sustained, always-on effect throughout a 24-hour period. And additional analyses have shown that the quote-unquote time in therapeutic range, meaning the proportion of time patients have a systolic blood pressure of less than 140 millimeters of mercury, is higher in those who received renal denervation compared to sham. And certainly we have seen multiple meta-analyses being published. I think at last count there was about 20. This is one published less than a year ago in 1,400 patients, 7 randomized trials, summarizing the pooled effect of renal denervation in these more recent studies, showing modest effects but significant. And I think Dr. Kanzari in his accompanying editorial does the nicest job of summarizing this. And basically he states that these studies affirm the biologic proof of principle for this novel technology and demonstrate a complementary benefit in uncontrolled hypertension despite prescribed medications. And we are now seeing other applications of this technology, both with AF, preserved ejection fraction, heart failure, and in obstructive sleep apnea. These are all conditions characterized by increased sympathetic tone. And now we're finally seeing guidelines and statements coming out from the European Society of Hypertension at the top, and a consensus document by SKY and the National Kidney Foundation essentially endorsing this technology. Certainly this is not commercially approved yet in the United States, but I think with this compelling evidence that has accumulated really in the last few years that's built on the lessons of Simplicity HTN-3, we may see this in the not too distant future. Thank you.
All right, next I'd like to welcome to the podium Dr. Mehdi Shishabor, and he's going to talk to us about deep venous arterialization for no option CLI. Is there hope? Dr. Shishabor.
Give us hope, Mehdi.
Well, thank you so much. Sounds like this session is all about hope, and that's fantastic because this is another technology where I think there is an opportunity and yet is not available yet in the United States, so similar to renal denervation. I don't have to tell this audience that there is a rise in the prevalence of critical limb ischemia, as you can see on the graph. And unfortunately, about 150,000 non-traumatic leg amputations are occurring in the United States yearly. Now, we are not suggesting that we can save all of those legs, but we like to save as many as we can. And hopefully, that's the message of this presentation. Basically, limb flow or deep venous arterialization is a process where we are not able to recanalize the arterial system and improve the blood flow to the foot. There's a traffic jam, and you are friends with the local police department, and you're able to jump on the other lane and get where you want to go through the venous system. And that's basically the gist of this procedure. There's a lot of different components to it. There's a little bit of a learning curve to get you going. You need to get pedal plantar venous access. This is a little bit challenging, and we can discuss it. Then you have to have an AV alignment to connect the venous system to the arterial system. Once you have the crossing from the arterial and the venous system, you then need to do valvotomy, because remember, we're getting the blood flow into the tibial veins in the opposite retrograde direction. So you need valvotomy so that the blood can make it to the distal foot. Once you have done the valvotomy, you need to place the stents. And the reason we cover the tibial veins from stem to stern is because we don't want steel. As you know, there's a lot of tributaries and a lot of collaterals in the venous system. We want to eliminate those so we don't have a steel. And then once we have that, we place a covered stent in the AV crossing between the artery and the vein. Once that's done, we have a deep venous arterialization, and hopefully we can get some blood flow to the patients. I'm going to discuss quickly the PROMISE-1 first in man trial. This was an early study to establish the safety of the technology, identify and address some of the limitations of these procedures. As you can imagine, something novel, new, and there's a lot to learn. And also determined, who would benefit from this kind of technology. It was 32 patients at 7 sites. The primary endpoint of the study was amputation-free survival with some of the subcomponents. And obviously, we were also interested in the wound size and wound healing. At the end of the day, we want to make sure that we can heal these patients. These were the investigators, and I was honored to be one of them. Bottom line, the baseline characteristics, obviously these are very sick patients. These are 70% of these patients are diabetic. There was a committee that decided that these were no option patients. So this wasn't like, oh, I cannot cross, this is no option. They had to really truly have no target for bypass, and they had to be approved by a committee that they could not be fixed in an endovascular approach. Majority of the deep venous arterialization was done through the posterior tibial artery, if you will. There's really 3 ways of doing deep venous arterialization. Below the knee, you can do it through the PT, you can do it through the AT, or you can do it through the peroneal. So majority of these were done through the posterior tibial, which we think is the best deep venous arterialization approach. The data, to my opinion, it was impressive because remember, these are patients that have no options. They are Rutherford class 5 and 6, and they are destined for amputation. So at least from my practice, the patients I enrolled, if there was no other option like DVA, they would be amputated. And in these patients, we had 77% survival. We had the freedom from amputation of 77%. This is at 24 months, not 6 months, 24 months. And we had 59% amputation-free survival. These are the patients that died. You can see that none of them were related really to the DVA or the procedure. They were cardiovascularly related. The last patient, number 5, obviously died at day 630 because of osteomyelitis. This is the data for wound. We made significant reduction in wound area, but I think the more important slide is this one. We had healing or healed of 92%, and more importantly, 85% of the patients, remember there were 32 patients, not 3,000, but still, this was the first in men. 85% of the patients had fully healed. Not only they didn't get an amputation, they fully healed with this procedure. We learned a lot, and it's going to be difficult to go over all of these with you, but I can tell you that there is a lot to learn from this procedure. We learned about the inflow, that you have to have an optimal inflow. We learned about the pedal access. You have to be very careful. These veins are very fragile, and if you damage the plantar vein, the whole procedure is destroyed. You cannot do it anymore. We learned about the AV crossing and some of the techniques to make it easier. We learned about the post-procedure. This is, you really have to be passionate to do this, because not just doing the procedure, it's the follow-up, the care of these patients, and the relationship with the podiatrist, because they are also not familiar with the care of these patients. It's very different. And then obviously patient selection. The paper was published in the Journal of Vascular Surgery, and we are now enrolling, we finished the enrollment in PROMISE 2. That data is going to be presented hopefully at later on this year at one of the major meetings, hopefully with a simultaneous publication. There were 105 subjects that were enrolled at 20 sites. And again, there was a lot that was learned. There were some modifications. But I really want to, in the last minute or so, show you one case that really highlights our passion for this technology, just like renal denervation. This was a 59-year-old female that I had treated, many years ago for the opposite leg, the right lower extremity. She had Church-Strauss. And unfortunately, at that time, we were not successful. So she ended up with a below-knee amputation on the left lower extremity. So I had a left leg below-knee amputation previously. Remember, she's 59 years old. She has vasculitis. She doesn't smoke, and she has never smoked in her life. She's on chronic steroid therapy. So now she came in to see me with the right lower extremity ulcers, and I will show you the ulcers. But the bottom line is that we did an angiogram in 2018. We showed that their inflow is beautiful. Everything looks great. We then went down to the lower extremity. You can see that the proximal tibials also look good. And if the AV folks in the back can play those videos, here we go. We see there's a little bit of trickling and tapering near the ankle. and you're not going to see much dye in the foot, I can tell you right now. And these are selective popliteal angiograms that are being performed. This is what we call a no-option patient. There are no targets. We attempted endovascular approach, and we think we are reasonable technically, and we were not successful. This is the ulcer that she presented. This was in January. We mucked around trying to do revascularization. In February, she was in a lot of pain. She was not doing well. Things were getting worse, and we were having difficulty with this. We presented the case to the company to be enrolled in PROMISE 1, the first in-man study, and they excluded her because of Church-Strauss. There were no options available at that time. So we went to the FDA, and we did a compassionate use with the company, LymphFlow, with the FDA, and with our institution. We agreed to offer her a compassionate use LymphFlow procedure. We performed the procedure for her in 2018. Again, the top pictures are before the LymphFlow, and the bottom pictures you can see are the LymphFlow pictures. Proud to say that within 4 to 5 months, she had healed these ulcers, but more interesting, look at her blood flow. She had flatline tibial and ankle pressures. After the procedure, 5 months later, her ulcers healed, and the arterial flow was significantly improved compared to before. At this time, the AV graft closed. But interestingly, she continued to do extremely well. This is 5 years later, almost 5 years later. She still has a leg. When we do her non-invasive studies, she continues to have excellent blood flow to her foot, which is something we still don't understand about this procedure, and we need to learn. So at the end, I just want to thank everybody, invite everybody next year to Austin, but emphasize that we think that this procedure will be another tool in the armamentarium, especially for patients with no option. Thank you very much.
Mehdi, thank you. That's just incredible stuff. I'm going to take the moderator's prerogative, and we're going to skip the discussion just to stay on time. And we still have one more discussion left at the end. So if you have questions, please hold them. I'd like to invite up Peter Monteleone, who's going to speak to us about deep venous. We just heard about that. My top 5 devices for lower extremity revascularization. I'm surprised you were able to limit it to just 5, Peter.
Wonderful. Thank you all so much for having me. My name is Peter Monteleone. I'm an interventional cardiologist in Austin, Texas. It's a unique opportunity to speak at such a wonderful meeting to such a remarkable group and a distinguished panel about 5 devices that I really like a lot. And so we'll dive in as we go. These are my disclosures as well as those of my group. As I built out this group of 5 devices that I enjoy using and I use frequently, certain criteria I used to build that list. One, I wanted to pick things that were broadly useful to me and hopefully to others in this list. I wanted to be a little creative in interpretation with what a device is or a category of device is. I was hoping to inspire someone in the group to maybe try something new and different. And I really wanted to represent kind of what I use and what I rely on. I spoke to my techs in the lab, I spoke to my fellows, I spoke to my colleagues about what would really even other people say about the 5 devices I use the most. And so we'll start with ultrasound. There's obvious reasons to use ultrasound. We use ultrasound for access in the lab. For me, one of my proudest clinical achievements was helping build out the non-invasive vascular lab in Austin, Texas. And ultrasound has completely changed the way I perform arterial procedures, even before we ever get to the cath lab. As an interventional cardiologist, you'll find yourself surprised sometimes about a patient with angina and a normal stress test, but they have a left main lesion. You never should find yourself surprised about a lower extremity arterial intervention. If you have arterial duplex data, you should know what you're getting into, and that'll change how you're prepping the patient, the time slot for the patient, even your conversations with patients. I can say I have multidisciplinary discussions with the vascular surgeons in my group about high-risk surgical patients for common femoral endarterectomies before they ever get to the cath lab, based on their findings of ultrasound, and that's a huge win for patients. Intra-procedure ultrasound, of course, is a game changer. You'll make decisions about where you're sticking a common femoral for access, how you're avoiding heavily calcified segments of that artery, how you're going low on the common femoral, perhaps for iliac occlusions or external iliac disease, will be completely revolutionized by using ultrasound. When we think about alternate access, ultrasound is what allows us to do that safely and effectively. Like in this case, it changes what could be an hours-long case using an expensive reentry device to get across an SFA lesion distally into a quick distal SFA stick using a Cook needle and a glide wire. Ultrasound lets us do that safely, quickly, efficiently, and our comfort with ultrasound is what lets us do that repeatedly in organized ways. Of course, tibiopedal disease, as Dr. Shishabor has spoken to and taught many of us about. Retrograde tibiopedal disease using ultrasound access lets us be efficient, lets us be confident and comfortable as we're doing these cases. It also lets us select where we can gain access easily in safe areas, avoiding compartments in the calf, and lets us get these most complex of cases done and done well. So ultrasound is a game changer, certainly one of my top 5. Next, we're going to have a wonderful talk coming from Dr. Feldman about drug-coated balloon utilization, but DCBs are absolutely one of my top 5. The data is overwhelming for use of drug-coated balloons. We have 12-month data demonstrating benefits against angioplasty alone, 24-month data with benefits against angioplasty alone. We have data looking at comparisons to using self-expanding stents in SFA and popliteal disease. That data goes out to 5 years in the IMPACT SFA trials that Medtronic provided us, showing us a freedom from CDTLR as high as 74.5%, which was true across some of our highest risk groups, diabetic patients, CTOs, long lesions. We in Austin, as well as multiple sites within Ascension Healthcare, are extremely proud to be part of the Elegance Registry with Boston Scientific, which is looking at use of Alluvia stents, but also Ranger balloons in patients, including women and underrepresented minorities, who are often the patients most harshly touched by the sequelae of peripheral artery disease, but who have been the least studied. And so Elegance is going to help us really learn about how we can effectively treat these patients. We're quite proud to be part of that trial. You can't mention use of DCBs and PAD without commenting on SCI consensus criteria that shows that the only thing that really has a guideline indication or a class 1 indication for data in in-stent restenosis is drug-coated balloon therapies. If you're not using drug-coated balloon therapies, you should be. Now, data gets something to be considered for my top 5, but operational utility is what really makes it part of my top 5. And so for me, DCBs is what lets me treat no stent zones. It gives me an option for treating ISR. It lets me avoid ISR. It helps me avoid permanent implants. There's good data about long lesions. And I challenge the operators that use a lot of drug-coated balloons to ask themselves, when was the last time you dealt with an acute thrombosis in an area that was treated solely with DCB? Those numbers are quite low, and those are the least fun cases we have. So certainly thinking from an operational standpoint about frequent utilization of drug-coated balloons makes a lot of sense. Next, specific. I use a lot of directional atherectomy. I'm a believer in directional atherectomy. That doesn't mean every 50% stenosis in an SFA is getting atherectomized, but that means I'm someone who believes in atherectomy as being not an aggressive therapy, but being a truly conservative therapy to help us try to avoid dissections that lead to lots of stents and no stent zones and all of these categories as we go. When you look for data for atherectomy, it is limited. We have the definitive series from 2014, looked at 600 claudicants and 200 CLI patients. Actually, in that subset, it showed some quite good benefits, 12-month freedom just with atherectomy alone at 78% in all claudicants, 71% in CLI patients. More recently, the REALITY study was designed to study the types of patients with complex lesions that we see in reality, and using the therapies that we use in reality, oftentimes a combination of atherectomy plus DCB. And we saw, even in these high-risk, heavily calcified, long lesion, 39% CTO patients, a freedom from TLR as high as 92% at a year. That data, honestly, could probably be improved as we talk about optimizing implementation science and utilization of atherectomy plus DCB. And again, operational benefits of atherectomy, specifically directional atherectomy for me. If I'm thinking about those highest risk complex lesions, common femoral, popliteal, no stent zones, that's where I use it. If you haven't used directional atherectomy since TurboHawk and SilverHawk, now in the days of Hawk 1, better cutting, better crossing allows you to target more complex lesions. I enjoy the artistic concept of it. I hate the concept of if you have an eccentric lateral lesion next to a common femoral at an osteal SFA, of just treating the whole thing. I like the ability to do discrete, directed cuts as we go. It avoids microdistal embolization, and part of it, honestly, is practical. You can be working in a lab where you don't work much, and if you ask for directional atherectomy, someone hands you 2 boxes, you know how to use them, and you use them. You don't need legacy equipment. You don't need special solutions mixed up. Next on my list, it actually came from one of my fellows, and they said, hey, one of your top devices is using a cart balloon, a reverse cart balloon. And I'm taking some broad painting of what it means to be a device, because any balloon is a cart balloon. When we think about cart or reverse cart techniques, what we're effectively thinking about is coming antegrade and coming retrograde, using a balloon from one direction to open a channel and then passing a wire through that channel. Again, any balloon, including your cheapest balloon and your smallest balloon, can be a cart balloon. That's very satisfying from an efficiency of implementation standpoint. Be careful working in the popliteal, be careful working in your iliacs. You can use IVUS to make sure you're carting or reverse carting intraluminally. But CART gives us the ability in cases like this one where we couldn't get across antegrade, we couldn't get across retrograde, to do a retrograde small balloon and then cross with an antegrade wire. Turns into a very safe, very effective procedure. In this case, which was complete obliteration of the tibial trifurcation, our antegrade wire didn't go, our retrograde wire didn't go. They came close to each other. We were able to advance an inexpensive coronary balloon up from the tibial, from the PT, and then advance our antegrade wire. So thoughtful mastery of CART and reverse CART really is our best defense against complex peripheral CTO. Last on my top 5 is a wire toolkit. I'm taking a lot of broad painting of what my definition is of a device here. But this is all I use. You know, I actually asked one of our technicians, when you think about me doing peripheral cases, what do you think about? And he said, use the same things every time. And so for me, I use woolly wires to go up and over. I sometimes use glide wires. I use as a workhorse an inexpensive nitrix wire. I'll use run-throughs for diffuse lesions and tibials. If I could see a microchannel, I cross it with a Fielder XT. If I have a short cap, I cross it with a Confianza Pro 12. If I'm coming retro, I use a V18 or an 018 glide wire. And that's it. That's the slide. So it's not one device, but there's this concept of I use the same things. I know how they feel in my hand. I know what I can do with or without them. And most importantly, that lets me move quickly and efficiently through my own toolkit, which is a huge piece of all this. It's also worth mentioning all these are on my shelf anyway from a coronary standpoint. So I'll end with that. There's this concept that the operator changes the tool, but the tool changes the operator. Aristotle said it best, and I think it's very true when you think about building out your own frequent uses, how to rely on them both in your classic common situations to be efficient and quick, but also in your most complicated cases. So thank you all so much.
Next, we're going to welcome up Dmitry Feldman. He's going to talk to us about innovations in drug-coated balloon technology.
All right, well, congratulations once again to organizers, and thank you to the moderators for the invitation to speak. I don't think this is the correct lecture. It should be the drug-eluting.
Just one moment, we're trying to sort through it. If it would be possible to move on to the next one, we can pull it up in the meantime.
All right, so we're going to let him upload his slides. We're going to proceed with complex femoral popliteal balloon knee cases. This is how we do it in Germany by Thomas Zeller. Thank you, sir.
Yeah, thank you. Well, I could talk about this topic for hours, but I tried to focus a little bit on the access topic, how to approach femoral popliteal and BTK lesions most appropriately. Well, what's a complex SFA lesion? I believe everybody agrees that that's a complex lesion based on the length of the occlusion. There's a small stump, which makes it easier to engage the lesion. You have some concave stump anatomical features, and also the distal stump looks accessible for retrograde access. But anyhow, the access to the lesion is key for success at the end. So if possible, antegrade access should be considered even for flush occlusions of the SFA. In this particular case, it's pretty easy if the patient is not too obese to use an antegrade access to have direct access to the stump of the occlusion. This is why I recommend in general the shortest possible access to the lesion. Then you should have access to dedicated re-entry devices. We have different devices available. The go-back catheter is the most recent development. It combines a crossing device with a re-entry device. Outback and Pioneer are already established technologies. Of course, this is something which is not an ideal anatomical condition to approach a right-sided common femoral artery lesion. Nevertheless, I tried it and I failed. This was the most extreme banded access or iliac access, and by the way, calcified. It was hard like rock, and this was impossible to get up and over here to the target lesion. So the way to approach such a kind of lesion is then to go retrograde. Of course, another access would have been the brachial. I wouldn't recommend the radial access for such difficult access anatomical conditions, but brachial would be an option. But much easier is the retrograde access. And here, this is the angiogram I did from the contralateral side. You can see they have a calcified lesion of the common femoral, including the origin of the deep femoral and the SFA. So it's pretty easy to get access from retrograde here into the proximal SFA, which was a big access artery, so the diameter is 6 to 7 millimeters. So not a big deal to get 6 franchises retrogradely in. This is the angiogram from the retrograde access. It looks not that great having implanted here a stent. It's a nitinol stent, but there was no pressure gradient left. The deep femoral artery was left here because the outflow to the foot, or let's say the BTK conditions had been very good. He had a 3-vessel runoff. And however, even using an angioseal system resulted in the creation of a false aneurysm, which was then treated again by an antigrade stick 2 days later. This was done by implantation of a stent graft. We decided to do that because the patient had also some disease in the distal SFA, what you can see over here. Again, very calcified, treated with lithotripsy and stent implantation in this second interventional approach. So it's important, if you are going to treat complex femoropopliteal lesions, that you have access to the entire interventional toolbox to guarantee long-term efficacy of your procedure. It's not only that you can do something, it should be of benefit for your patient, so the patient should be relieved from his symptoms, and that means that you have to have access to all these interventional tools. And this is what you need to consider depending on complexity of the femoropopliteal lesion regarding the devices that you can apply. In my institution, task A and B lesions are in general treated primarily with Dcb and provisional stent placement. Stenting can be also tech placement if you have access to those short scaffolds. If the lesion is becoming more complex, it's more likely that you will need another kind of scaffold, whether this is a superior stent for calcified lesions or drug-eluting stents, or even wire-band endoprothesis for the real long lesions, task D lesions. And finally, of course, you can still consider a surgical approach. Quickly go into the BTK interventions. Again, appropriate access. Even in extremely obese patients, I prefer the antegrade stick, so that means the stick from the same side as the lesion is located. So ipsilateral access, it can be easily done by use of ultrasound. Then I prefer to use coaxial techniques. That means I work with a 100 centimeter long straight guiding catheter, and then I can use every kind of over-the-wire or even rapid exchange device combined with different guide wires. The guide wire topic will be discussed in another talk later during the next upcoming session. So I would like to conclude with 2 case reports. This is a patient with critical limb ischemia with total occlusion of all 3 BTK vessels, heavily calcified in the distal segment. The anterior tibial was the culprit lesion here because it was the only foot-providing artery. A pretty good outflow into the dorsalis pedis artery. The peroneal artery diseased distally, so it was not a very good collateral providing vessel. And I got stuck in this calcified lesion from the antegrade access. Double wire technique was used, pre-dilating, subintimal channel. Everything did not work, so a retrograde stick was necessary, and this is what you need to have in your personal skill toolbox. You need to know how to access retrogradely even small access arteries with a dimension of 1.5 millimeter in some of these circumstances. Then this is what is already presented as a CAR technique. You go with 2 wires from antegrade, retrograde, you pre-dilate even from the retrograde access if necessary. Then the lesion was crossed successfully. Stents had been implanted, drug-eluting stents. One of the most important top 5 devices, in my opinion, for BDK disease is access to coronary drug-eluting stents. They can be even implanted into the distal anterior tibial. This was the outcome, and I will finish this case report with 6 months angiogram. You can see the artery is still widely patent, and even the access artery is patent. There is no restenosis and even a better vessel lumen. And finally, this is a patient with recurrent occlusions of a femoropopliteal bypass, which was implanted due to popliteal artery aneurysm. You can see here one vessel runoff into the peroneal with a good collateral flow to the posterior tibial artery. And the idea to prevent these recurrent reocclusions of the bypass graft was to improve the outflow, to reestablish a 2-vessel runoff. So again, retrograde access here into the posterior tibial artery. This is selective angiogram from retrograde. The challenge here was multiple stents implanted. I'm coming to my conclusion very quickly. Yeah, so step by step, I was able to establish access to the tibioperoneal trunk by retrogradely using the Outback system. Thereafter, the bifurcation was reconstructed with drug-eluting stents with this angiographic outcome, and the result, clinical result, was a 2-year patency of this reconstruction and no recurrent reocclusion. Thank you very much.
Thank you, Tomas. That was outstanding, and I'm sure just a sort of a teaser for the session that will follow this after a 30-minute break, Master's Approach to CLI. We'll now have Dimitri Feldman come back up, hopefully with the right talk, and we're going to hear about innovations in Dcb technology.
All right, thank you, Herb. So the last talk will focus a little bit on what the evolution of Dcb technology looks like and what the sirolimus-eluting devices that are being currently worked on look like in the future. I don't have any disclosures relative to this. If we want to develop newer DCBs, better DCBs, we need to understand what is the optimal DCB. So first of all, which drug? And what we understand from the coronary literature, number one, is that paclitaxel didn't perform as well as the Limus type of drugs. At least from the coronaries, we know that. You need to deliver full drug to the target lesion, avoid drug loss during the transit, that's important, prevent particular embolization downstream as not to cause ischemia. We'll talk a little bit about that. You have to deploy the drug during PTA, meaning you need timely, consistent, and accurate delivery from balloon to the target lesion. Once inside in the intracellular space, you need levels of the drug sufficient for desired therapeutic effect. You need to avoid rapid drug degradation, and of course, once inside intracellular space, the drug needs to work. It has to be sustained release at least 4 weeks, similar to what we have in the DES construct. So what do we have now? Paclitaxel, the drug that we well know, it interacts with the M mitosis stage. It interferes with cell division, essentially halts cell division and causes apoptosis, cell death. What about Limus type of drugs? They actually interact at the protein synthesis stage, and so they have some anti-inflammatory and anti-restenotic effects, broader therapeutic range, 100-fold higher margin of safety. But what is the problem with the Limus drug? 2 problems. Tissue absorption, due to its hydrophilic nature, is slow, and tissue retention is very short. If you can solve these 2 problems and create devices, I'm sure the companies would love developing Limus type of drug-coated devices. Let's look at the data for the paclitaxel devices. Looking at the DCBs versus drug-eluting stents with paclitaxel, overall, not head-to-head comparison, but overall, the primary patencies, secondary patencies are similar. We've all heard the 2018 drama after the meta-analysis of Katsanas with the paclitaxel devices being potentially implicated in long-term mortality, FDA warnings, the trials have been halted. Luckily, since then, we've understood the data a little bit better. We have more data that have come out. As you can see, 2 papers from Eric Zakemski looking at the long-term outcomes in the Medicare population of DCB devices and DS devices. And as you can see, there was no concern, at least in these studies, with long-term mortality. The Kaplan-Meier curves are essentially superimposed. Let's talk a little bit about this increased risk of embolization. Thought to be hypothetical, but maybe not hypothetical. The animal studies did show, as you can see on the right, that post-delivery of paclitaxel-eluting devices, you do see this crystalline material distally with fibrin and thrombus on top of it. And it varies depending on which device you use. So it depends, for instance, whether it's a device that has a lot of paclitaxel and how it's coated. Unfortunately, we would love to have a DCB for below the knee, but most of the trials we've had so far have been negative. Some have been stopped due to safety concerns, but we don't have yet good data for DCB in below the knees interventions. On the other hand, when we look at the sirolimus data, at least in the coronary literature, sirolimus versus paclitaxel, we have over 70 studies. This is one of the meta-analyses that clearly suggests that limus drugs are more effective at preventing neointimal hyperplasia and restenosis. So what do we need to create better limus drug-coated balloons? Well, we need to address the 2 problems I mentioned, and so the 2nd generation and 3rd generation sirolimus-eluting balloons have been developed. These rely on so-called spray-coated nanocarrier technology or nanosphere encapsulated technology. Let me show you a couple of balloons that are currently being investigated. The solution SLR, and this technology is really relying on so-called micro-reservoir technology, where you have little reservoirs of sirolimus and biodegradable polymer, which allows pharmacokinetics release more stable, and within the 90 days post-treatment, you have a very steady release of sirolimus. Now, that's been shown, and indeed, when you compare it to paclitaxel balloons, the amount of drug that is lost from the balloon upon delivery is less, which means more of the drug gets transferred to the vessel, which means you need to use less of the drug in general, and the drug that gets into the vessel stays there for a longer period of time, at least for over 3 months, as has been shown. Do we have data? Well, there's a little bit of data, 25 patients in the Prestige trial. It has been published, 6-month results, 18-month results have been presented. Very sick CLI, below the knee population, mostly Rutherford 5 with end-stage renal failure, diabetes. But as you can see, overall, pretty interesting result. TLR rates at 18 months, 88%. Amputation-free survival, 80%, wound healing, 80%. So encouraging data. The other technology, also sirolimus-coated balloon catheter, relies on sirolimus that's encapsulated in phospholipid with proprietary nanolute technology. But essentially, phospholipid is the drug carrier for these 2 lipophilic tails and 1 hydrophilic head that holds the sirolimus. Then partly refolded balloons are coated with this technology, then they refold it, and so that allows the sirolimus sort of to elute a little bit more steadily. And that has been studied as well in the Odyssey trial, a small trial, 50 patients. Both femoropopliteal as well as below the knee population was studied. The technical success was good. 12-month freedom from clinically driven TLR, 90%, amputation-free survival, 81%, limb salvage, 92%. Once again, very limited data, but encouraging. Ongoing trials of these balloons are going in both below the knee population, in the femoropopliteal population, as well as in AV fistulas. And they are being compared now to mainly plain old balloon angioplasty, but some of the trials are starting to compare this to the paclitaxel-eluting technology as well. So in conclusion, the limus analogs represent a promising alternative in the treatment of disease in the peripheral vasculature. The current data for below the knee with the solution SLR, DEB, and MAGIC touch sirolimus balloon, as I showed you, are encouraging. We have good 12 to 18-month patency without any major adverse events or device-related shortcomings, but ongoing trials will investigate the efficacy and safety of these balloons, both in the femoropopliteal and below the knee populations. But what we really will need later is a randomized trial comparing to the paclitaxel devices to see if this technology is superior to what we currently have. Thank you.
Dimitri, thank you. Unfortunately, I'm afraid we're out of time, and we don't have time for the discussion, but I do want to thank our panelists for excellent presentations and excellent dialogue. I want to thank the audience as well. I'll encourage you to stop by the exhibitors during this 30-minute break and to come back at 3:30 for Master's Approach to Critical Limb Ischemia. Thanks.
Yeah. Yeah, I still do some of that. Yeah. Oh, wonderful. That's